So I'm now going to talk about response criteria and kinetics with immune checkpoint inhibitors. And these are my disclosures. And this is what it's all about. So here we have one of the patients which we treated with squamous cell lung cancer, who was treated first with gemcitabine carboplatin, afterwards got a recurrence of disease, and then was treated in the nivolumab docetaxel arm. He was included in the nivolumab arm, and here you can see the skin mets, and now 2.5 years later, they're still in a remission, because you can see here there's still some kind of a lesion there. But what is quite striking is that his CT scan looked like this already from September onwards. So 2 months, let's say 6 weeks, because then we made the CT. So 6 weeks after the start of the treatment, he already had this huge partial response of his malignant disease. And that's what I'm going to discuss about. So something about the response criteria. So we have to keep in mind that immunotherapy is quite different from the other treatments which we usually give, like chemotherapy. There are now the the immune-related response criteria, which I will touch on. I will say something about the kinetics of response, something about pharmacokinetics, and I focus mainly on the PD-1, PD-L1 axis, because the effect of the anti-CTLA-4 may be different. And also what we see now is that the anti-CTLA-4 as a monotherapy does not seem that effective in lung cancer and mesothelioma. So, for instance, this week we heard that the second, third line randomized trial of tremelimumab versus placebo was negative in mesothelioma. So I will only focus on PD-1, PD-L1. And we have to keep in mind that when we look at the response criteria, so for instance, the RECIST criteria, that these are research-driven. So these criteria were made to guide us to get an effect of treatments in the scientific world, but not for for clinical situations, so not for patient management. And there was already written in the original paper from 16 years ago that they say, well, novel therapies could come up where it's not about tumor shrinkage, but just which work on another mechanism, and probably the RECIST criteria are not of value for this kind of treatments. And the other thing they say also is that it might be appropriate to make a distinction between clinical improvement and objective tumor response. So also in their criteria, they already wrote that when a patient is having a clinical objective response, you could continue on treatment. And the question is whether this is a major issue in patients treated with PD-1, PD-L1. And this is from the squamous cell paper from the supplementary data. And it took me quite a while to get through these figures. But what you see here is that these are patients who are treated beyond progression. So these patients were having a progression of disease. And when they had a progression of disease, that was set at 0 again. And these patients were allowed to be continued on treatment in the trial. So when they had a RECIST progression of disease, they were allowed to continue on treatment. And what you see here is also the green line and the blue line. And the blue lines are these patients who are having either a complete or partial response on the nivolumab. So these were patients treated. They got a major response with a partial response or a complete response, and then there was a growth of their tumor again. So it could be that they had far less tumor than they started with, but there was a growth of the tumor. And these were continued on treatment that you see in blue, and the green ones are the ones who didn't have any advantage of the treatments, that is to say, they had stable disease or a progression of disease as their best response. And these patients were continued on treatment, and you can see here in this spider plot what is happening, what is the fate of these patients when you continue on this treatment. And what you can appreciate from this is that it is not that simple. So what I here indicate with the arrow is the right triangle. So that means that you have a patient who was responding on nivolumab, then got a RECIST progression of disease, was continued on treatment, got a response again, but then here he got a new lesion. So the right triangle means a new lesion. So there was a new lesion occurring half a year after the start of the treatment, and when they continued him on treatment, he still is being in a remission. So it's quite complicated to look at how you look at your CTs and how you incorporate RECIST into the treatment of these patients. And what I then did is that also in the supplementary data, they provide the individual patients who are treated beyond progression, and then they gave the number of cycles of nivolumab they were treated with. So there were 28 patients treated with nivolumab after RECIST progression. And what you can see here is that 17 of these patients were only treated with 3 or less courses. So that means that they had a progression, they were continued on treatment, but then after re-evaluation it was stopped. So 17 of these patients who were treated after progression, in my view, were treated unnecessary because they had real progression of the disease. On the other hand, you have 9 patients who had more than 6 cycles. So these patients were having progression of disease, and when you continue them on treatment, you see that they keep into remission for longer times, for over 3 months. So probably these are the patients who benefit. So it's not that simple how to select for patients who benefit, because the reason for continuation of treatment was that they were allowed to have a RECIST progression, but their clinical conditions should be as good as they started. So, why should we use then these response criteria when it's so difficult? Why just not ask the patient how he's feeling? Well, of course we have this absence of the reliable biomarker, so we don't know how to select optimally for the patients, which was already discussed. We have to keep in mind that we want to prevent the patients from undertreatment. So as was shown, the patients who are continued on treatment with 3 additional cycles but then got progression, they may lose the chance of being treated with docetaxel in combination with the anti-angiogenic agents. So they may be under treatment by continuing with the immunotherapy. And the other way around, you want to prevent both the patients and society from this overtreatment, that you continue on a treatment which is not effective and leads to higher costs. And one of the things which was developed were these immune-related response criteria, and I will go over that in detail, but I don't, well, probably is readable. But you know already we have the RECIST criteria, the RECIST 1.1, and when you look at the sum of the longest diameters of the lesions, and when there's a more than 30% decrease, you call it a partial response. When there's more than 20% increase or a new lesion develops, then you call it a progression of disease, and stable disease is everything in between. The immune-related response criteria, according to RECIST, you need a 50% or more decrease in tumor burden from baseline. And to call something a progression of disease, you need to have a 25% increase in the size of the tumor burden, which should be confirmed 4 to 6 weeks after your first establishment of progression of disease. So this means that when you get a progression of disease, you continue on treatment, repeat the scan. When the disease is then stabilized, you continue. When it increases further, then you should stop your treatment. Then you call it the real progression. And what is also included in these immune-related response criteria is that a new lesion does not mean progression of disease, but a new lesion you add up to the sum of the longest diameter. So when you got a new lesion, you just add up the sum of that diameter to your sum of lesions, and then you look what is the total increase of these lesions. So that was done in RECIST, and that is also done in the WHO criteria. So in the WHO criteria, you look for bidimensional measurements, and when you have let's say the normal WHO criteria, you should have a more than 50% decrease in the sum of the diameters to call something a partial response, and a 25% increase to call something a progression of disease. And also in this is allowed to include new lesions in the sum of these diameters and confirm this. So this WHO is, I think, more used in research, but now with the RECIST it's more easy to do. But this was mostly studied in the first trials. And is this, has this a clinical value? Well, this is from one of the first papers where they used it and they developed it. This is from a melanoma patient treated with anti-CTLA-4. And what you can see here with the asterisks are those patients who should have been who should have had a progression of disease according to the WHO criteria, so to the normal WHO criteria, but who were continued on treatment because they made the immune-related WHO criteria, and then these patients did respond. So in this study, 22 of the 176 patients were having progression of disease according to the standard response evaluation, but because they used the immune-related criteria, they were continued on treatment, and you can see again, just as we saw in the lung cancer, that these patients were having a clinical benefit. And this is one of my patients, which we treated with the anti-PD-L1 drug of Roche to make it more complex. And this is a patient who got a lobectomy, and then this was his only measurable lesion, which was an adrenal gland. And he was treated with the anti-PD-L1 antibody, and in September there was a stabilization of disease. It's still 39 millimeters. And in November we saw a slight increase of his adrenal gland, but also you see a new lesion appearing in the liver. Because he was in good clinical condition, I continued him on treatment, and in December you can see here there was a fast enlargement of this adrenal gland and also the liver met, and there was a new lesion occurring here. It probably is already there, but we then missed it, but now you can see it here. And I still continued him on treatment, and now in March 15, you can see here there's a total FDG regression of all lesions, and now we are here in January 16, and he's still in complete remission. So to show how complex it is, because it could also have been that here he was progressing and we missed the opportunity to treat him with chemotherapy. And this is something about non-target lesions. Another patient also treated with this PD-L1 compound. He had a bone met, and then you can see after 6 weeks of treatment there's an increase in this lesion, and then after 16 weeks there's a complete resolution of the lesion to become FDG negative, and also remain that after 22 weeks. So again, you can see that this is not that the increase in FDG avidity or increase in size does mean that it's a progression of disease like we normally did. But then I want to, because otherwise we could think, well, we don't have to look at responses, but I think the responses on immunotherapy are of importance. And what I did here, and you already saw another example, but what I did here is again from the supplementary data, look at the swimmer plot. So where you can see here all the responses. So these are all the patients responding on nivolumab, and the arrows means that they are continuing on treatment. And this is the overall survival curve, and I put a bar at 1.5 years. And what you can see here is that after 1.5 years, there are no events, and so all these squares are censored. And you have to believe me, but you can recount it, that these are 11 patients. So there are 11 patients here beyond this 1.5 years of treatment. And when you look at these bars, from these 11 patients, 9 are having a partial response. So what I want to show with this is that to be a long-term survivor on immunotherapy, in my view, you need a response of the tumor. So all these patients who are having disease stabilization are the ones who could be who have a shorter benefit of these kind of drugs. So that's a hypothesis that maybe in patients who are having disease stabilization with nivolumab or other PD-1, PD-L1 drugs, we should give combination treatment in order to induce this response. So, to conclude from this, I would say, well, treatment beyond radiographical progression may be an option in case of the general well-being of the patient. In general, immune-related progression happens mostly early. So the the patient I showed you with the long term, that's quite exceptional. In general, this immune-related progression of disease happens early. And of course, you have to keep in mind, are there other effective treatments for this patient? So when there is a progression of disease, what kind of treatment can this patient tolerate? And that's, of course, again, the issue of shared decision-making, because you have to discuss your own uncertainties about the value of continuation of this immunotherapy with the patient, discuss the other treatment options, and then together with the patient decide which kind of treatment you are going to continue. Then back to this swimmer plot again. So showing here all the nivolumab patients, but here in black are shown when the response did occur. So what you can see here is that these are all responding patients, but what you can see is that most of these patients do respond quite early after the start of treatment. So again, just to show you, the example I showed you is an exception. Most people, when they respond quite early after the start of treatment. Again, also here there's a late responder, but mostly these patients do respond early. So the kinetics of response is when there is an activation of the immune system, you can see a quite quick resolution of tumor tissue. In the last part, I will just discuss something about pharmacokinetics of these drugs, because I think this is quite underestimated, and there's a very nice review on that on phase 1 studies with immunotherapeutic drugs, which is now available from the Annals of Oncology. And there are quite limited data about the pharmacokinetics of these drugs. And we have to keep in mind that nivolumab or all these PD-1, PD-L1 drugs are IgG antibodies. So there's, in general, a half-life time of 16 days, but it can differ from 9 to 21 days. And also, what we have to keep in mind is that the clinical activity may be different in same dosages between the same drugs. And it's going to take a lot of time to talk about, but these drugs are either IgG1 or IgG4, and this is about the tail of the antibody, and this tail of the antibody has an effect on the activation of different kind of immune cells. So you have this antigen-dependent cell death occurring with these agents also. So you can imagine that, for instance, with IgG4, you get more activation of natural killer cells when binding to the tumor cell. That can cause also tumor cell killing, but on another way than what we are thinking of in general when we talk about immunotherapy. There is also a soluble form of PD-L1 in the blood, so they can also inactivate some of our drug, and we can get the development of anti-antibodies, which is not quite often seen in human antibodies, but there is some kind of a humanized antibodies that can be seen. What we don't know from all these drugs is it like targeted therapy, where we should keep a continuous pressure on the tumor, or whether it's an on-off phenomenon, that when you take the switch and the immune system is activated, that you can stop your drug. We now give it for Q2 weeks or Q3 weeks, but maybe longer intervals are possible, or stop it and then reintroduce the drug after progression of disease. That we don't know. There's no clear correlation between the dose, efficacy, and toxicity. So it's not that we know that higher dose causes more toxicity. There's no relationship between that. And it will also be that with different antibodies or different working mechanisms, toxicity may be different. So PD-1, PD-L1 is an antibody, an antagonistic antibody, but probably some of these agonistic antibodies will have different toxicity profile. And I will not go into detail of this figure much, but it's just to show you how our concept of the development of drugs has changed now. So in general, with the cytotoxic chemotherapy, we did do studies, phase 1 studies, with a very small proportion of patients, elevation of dose, to find an active dose, or to find a dose for toxicity, then take it to phase 2 studies, and then to phase 3. But now, with the immunotherapy, we get large phase 1 studies with large extension cohorts to look for all kind of correlates with the immune profiling, and then these drugs are taken into phase 3. So, to conclude, I think the take-home messages are that for the response criteria, we can treat beyond progression. the immune-related criteria may add to your clinical decision-making, but still the clinical condition of the patient is paramount. For the kinetics, we have a lot of missing data about pharmacokinetics and pharmacodynamics, and we also don't know what is the optimal dosing schedule. And with that, I'd like to thank you for your attention.